For decades, the mantra in medicine has been simple. When it comes to blood pressure, lower is better. We've been conditioned to believe that a perfect score of 120/80 is the gold standard for health. However, a growing body of evidence, including a landmark study
published in the Journal of the American Medical Association,
is forcing us to reconsider this one-size-fits-all approach, especially for our aging population. What if, for a healthy 80-year-old, a slightly higher blood pressure isn't just okay, but actually safer? This question is at the heart of a significant shift in our understanding of cardiovascular care. The study in question tracked over 15,000 seniors for 5 years. The results were startling. Researchers found that seniors with that so-called perfect blood pressure of 120/80 summer mirror scars had a 28% higher risk of serious falls and worse overall survival compared to their peers with moderately higher readings. This challenges the very foundation of how we've been managing hypertension in older adults and highlights a dangerous gap between research evidence and everyday clinical practice. The problem often begins with a well-intentioned doctor's visit. A 78-year-old patient comes in with a blood pressure of 145/86. The physician, following general guidelines aimed at a middle-aged population, prescribes a stronger dose of medication. A month later, the numbers look great on paper, 124/78. The doctor is pleased and the patient leaves. But what the chart doesn't show is what happens when that patient stands up to go to the bathroom in the middle of the night. Suddenly, their pressure plummets to 88/56. They become dizzy, lose their balance, and suffer a fall that could lead to a hip fracture, a loss of independence, or worse. This scenario is alarmingly common because most doctors are not routinely testing for orthostatic hypotension, a dangerous drop in blood pressure that occurs when standing up. This gap in practice is causing preventable harm. For middle-aged adults in their 40s and 50s, aggressively lowering blood pressure is beneficial. It reduces cardiovascular events.
But after age 75, the evidence tells a different story. For this demographic, a systolic pressure, the top number, sitting between 145 millimeters of mercury, is consistently associated with longer survival, fewer falls, fewer hospitalizations, and better cognitive function.
Why does the rule change as we age? The answer lies in 3 key physiological changes that occur in the body. First, there is arterial stiffness. As we get older, our arteries lose their elasticity, much like an old garden hose that becomes brittle. This stiffening means the arteries can no longer absorb the pressure waves from the heartbeat effectively. Consequently, a higher baseline pressure is required to maintain adequate blood flow to vital organs, especially the brain and kidneys, when we are upright.
Second, we experience a decline in baroreceptor function.
These are tiny pressure sensors located in our blood vessels that act as our body's internal stability control. They constantly monitor pressure and send signals to the brain to adjust heart rate and vessel diameter as we change posture. In older adults, these sensors respond more slowly and less effectively. When a senior stands up, their body is slower to compensate, leading to that dangerous drop in blood pressure we discussed earlier. Third, we must consider medication metabolism. Aging kidneys and livers simply don't clear drugs from the system as efficiently as they once did. Blood pressure medications can linger in the body, accumulating to levels that cause excessive and prolonged lowering of pressure, chastain turning a therapeutic dose into a toxic one. This is why starting low and going slow with medication adjustments is critical in older adults. Rushing the process often does more harm than good. Given these changes, the detailed findings from the JAMA Internal Medicine study provide a clear roadmap.
The study categorized blood pressure outcomes in adults over 75. Those with systolic pressures below 120 millimeters of mercury had the worst outcomes,
including that 28% higher risk of falls, a 14% higher mortality rate, and increased rates of acute kidney injury.
Conversely, those with pressures above 150 millimeters of mercury
face the highest risk of stroke and other cardiovascular complications. The optimal sweet spot for survival and quality of life was clearly the 130 to 140 mmHg range. So how can older adults and their families navigate this complex landscape? It starts with moving away from treating a number and moving toward treating the patient. If you or a loved one is over 70 and on blood pressure medication, here are practical steps to take. First, become a home detective. Invest in a home blood pressure monitor. Don't rely solely on the single reading you get in the doctor's office. Measure your pressure twice a day, morning and evening, for 2 weeks to get a true average.
This provides a much better pattern than a single snapshot.
Remember, blood pressure fluctuates naturally throughout the day, so a collection of readings tells a far more accurate story than one isolated number.
Second, perform the orthostatic test. This is crucial.
Lie down for 5 minutes and take your blood pressure. Then stand up and take it again immediately. If your systolic pressure drops by more than 20 points, for example, from 78 lying down to 64 standing, you have orthostatic hypotension. This is a major red flag that your medications may be too strong or your target is set too low.
Third, assess your symptoms. Do you feel dizzy when you stand up? Are you unusually fatigued? Do you experience brain fog? These are not normal signs of aging. They are often signs of excessively low blood pressure.
If you notice these symptoms occurring within a few hours of taking your medication, that timing is a valuable clue to share with your doctor. Finally, advocate for individualized targets. When you go to your doctor, don't just ask, "What is my blood pressure?" Ask, "What should my blood pressure target be, given my age, my health status, and my level of frailty?" A healthy 81-year-old who plays golf daily has vastly different needs than an 81-year-old with heart failure and osteoarthritis, even if they have the exact same blood pressure reading of 158/88. The healthy golfer may require only lifestyle changes to aim for a comfortable 145/84. While the frailer individual might need cautious, low-dose medication to land in the 140-145 range, prioritizing fall prevention above all else. Let me leave you with a story that illustrates this principle. I recall a patient named Eleanor, an 82-year-old former librarian who was sharp as a tack. She came to me after a hospitalization for a fall. She was terrified, not of falling again, but of losing her independence. Her blood pressure was 110/70. Her previous doctor had been so focused on getting her numbers down that he had pushed her medications to the limit. She was dizzy every time she stood up. We reduced her medication, aiming for a target of 145/85. Within a week, her dizziness vanished. 6 months later, she was back to volunteering at the library, walking without her cane, and her blood pressure sat comfortably at 142/84. She wasn't a failure of treatment. She was a victim of a protocol that didn't account for who she was. The takeaway is simple, yet profound. Blood pressure targets should not be universal across all ages. For older adults, a systolic pressure between 130 and 145 mmHg is often the optimal range for survival, independence, and quality of life. By understanding the risks of aggressive treatment, testing for orthostatic hypotension at home, and partnering with your doctor to individualize your care, you can navigate this journey safely. Treat the patient, not just the number, and you will not only add years to life, but more importantly, life to years. After all, the goal of healthcare isn't just to achieve a specific number on a monitor. It's to ensure that our later years are lived with vitality, dignity, and the freedom to enjoy the moments that matter most.